So ADHD is very prevalent among 8 to 15-year-olds. They're 6 to 9%, and then um, obviously there is like a spike in ADHD numbers with COVID-19 and such, and hence there's also a big shortage of medications to treat ADHD at this time, and there's a big supply-demand type issue with various companies that provide the medication to the pharmacies and such, because they say one is like not really overdiagnosis, it's more like people actually came out of the woodworks to get help during COVID time, and more people sought out mental health help, and then they were also happened to be diagnosed with ADHD among other comorbid conditions. So more of these medications that have been prescribed and such, are the reasons for the shortage right now. But anyway, we probably all have met somebody with ADHD, and I won't kind of bore you with the stats here, but it is um, associated with high degree of psychiatric comorbidities, like kids with ADHD may have oppositional defiant disorder or ODD. So they may be, a behavioral challenge in schools with, for teachers and others, and even a challenge at home. They don't like to listen to authority figures and such. The ADHD child may also have impairment in multiple domains. They may not be able to just focus and things like that, but they may be also socially not so good because that ADHD brain is actually lagging in development, where they may be a little bit more immature. So even though they may be like 8 years old, but because their brain is all over the place and not really focused all the time, they're not really learning enough for their age level, and they're kind of missing certain things. So they end up like really behaving more mature, like a 6-year-old or 5-year-old. So there is that type of issues as well. If you really follow them, you may have to correct various things in therapy and also through medication. So it is a chronic course. Some of the hyperactivity and impulsivity type symptoms kind of disappear slowly as the brain is developing, and I think I covered it in the first presentation, but as the brain gets more myelinated and things like that. So that's basically like the brain is growing into. So actually, now I'm thinking of a different group that I presented to. Okay, so I didn't really cover that, but our brain kind of goes through different phases of development, and as it matures, it's the neurons or the brain, wires in one sense, are getting insulated, so we call it myelinated. So as it gets insulated, the circuit is a little bit more calmer, direct, and it functions better. But it takes that entire teenage years and all those years to kind of slowly the myelination to kind of catch up, and the girls, are the female brain is usually myelinated a little bit earlier, so females are actually more mature for their age um, compared to a male. So that's why you probably see that discrepancy no matter the culture. So females are a little bit more mature, and then the male brain usually catches up with the myelination and everything, and by like age 25 or so, or even sometimes a little bit later because of delay in development and all that. So that process happens, and you'll see for those reasons, the male is like more impulsive, risk taking, and making poor choices and things like that. Anyway, ADHD is a clinical diagnosis in both youths and adults, and sometimes they come to us at a very young age because the symptoms are all over the chart in the hyperactivity area, the impulsivity area, and the inattention area. So those are the three usual areas that we are looking at just for the ADHD component, and and then obviously the teachers can handle them, the parents can handle them at home, and the kid is always need somebody to watch them, or maybe the child is also getting abused because of the ADHD. The parents may be hitting them, other kids may be kind of bullying them and fighting them, uh, and things like that may be happening. So, ADHD diagnosis is kind of obvious once you start to hear, some of the details they start out saying, and then it is a quick diagnosis. You just have to, also kind of make sure the symptoms are happening in different settings, like school and at home. And sometimes when they come to the office, they're behaving well for that limited time because they know the doctor may give them an injection or medication, something, and they're like well behaved, and you may not see all the symptoms right away. But then the parents are wondering what's going on here. The child is not presenting any symptoms, and this is not how he is at home. So they think like sometimes this is all an act, when the child is kind of being very careful, not to show the symptoms and all that. And then anyway, there are medications once we diagnose, and we can treat with medications of psychostimulant type or non-stimulant types. So we'll kind of get into that in future slides. So this is just a picture of a postsynaptic neuron and a presynaptic neuron firing off. And so these are basically dopamine or norepinephrine that are first, put into packages and put into these vesicles, to protect them from getting, broken down again, because there are enzymes in the nerve cell also that can break this down and, back to the building blocks, and then the building blocks have to make it again. But once it's in a vesicle, and when there's a need, it comes to the receptor area and discharges, the dopamine and norepinephrine, and that binds to the receptor in the postsynaptic neuron, right? And this is synapses, basically means the gap between this neuron and that neuron. So once it's released into the gap, it'll also fit into these receptors that I'm showing. If you can see, like these are getting fitted into, and sort of like a lock and key. And once it fits into that spot, basically the message that what this postsynaptic neuron is supposed to do kind of does. It's sort of like maybe it's a particular action that it needs to do. So the postsynaptic neuron is firing, and then it'll kind of take care of the rest down the brain pathway. So that's like a basic look at the neuronal level. And so what medications, so sometimes, so this is the transporter to kind of get it out of the presynaptic neuron to the postsynaptic neuron. So the transporter itself is a place where treatment also happens, or there's issues with, because of issues at the transporter level, there are also deficiencies in adequate number of dopamine and norepinephrine crossing into the synapse. So there are various types of medications available. Alpha agonists, they work a different way, but ultimately they can also help in the release of dopamine and norepinephrine. There's amphetamines who are directly increasing dopamine release. And those medications, amphetamines and methylphenidates, are the ones, they're also blocking the reuptake. So anything that's unused usually gets, pulled back in. So that's through the transporter. And if you block it, basically you can pull the, not pull the dopamine back, and the dopamine will hang around in the synapse, and then this postsynaptic neuron sometimes will increase the number of receptor sites for that particular, dopamine and norepinephrine, and then the firing will continue and, help them focus better in that sense. So the goal obviously is to kind of have like increased neurotransmitters, binding to the receptors and the signal being, triggered and all that. And then there are other medications as well, like atomoxetine, that's like a non-stimulant one. And then there are newer ones as well. And there's Wellbutrin, also, that's also a dopamine and norepinephrine agonist, so it helps releasing it. But there are medications that can help release it into the synapse, also block from getting um, recycled back into the presynaptic neuron, and once it's recycled back, the components go back, and they're again going to get made into dopamine and norepinephrine and released back into the system. So it's sort of like a feedback system and all that. Anyway, not to bore anybody with those pictures, but so diagnosis is something we have to know. Like I said, we have a set of symptoms that we look at with impulsivity and hyperactivity and inattention and focus and all that. And among all the symptoms, 6 out of 9 symptoms of inattention hyperactivity will give us, if both are met, we call it combined type. And then if 5 out of 9 is met, and if the person is more, in a person that's more than 17, it can be diagnosed at a later age. But usually most of these symptoms are present from a younger age, but some people are only coming to us at a later age because 17 is the age when most of the time kids are going off to college or they're in the senior year, and they're having like great difficulty kind of getting through the senior level classes or college level classes, and because the workload is too much and they feel like they can't focus and all that. So we have to be careful, if sometimes if it's true ADHD, or if it's something related to them not having good study skills and good habits and all that to sit down and focus and get the work done. And so sometimes intelligence is not a question in these kids. It's because of the intelligence is how they sometimes have managed their ADHD symptoms, and they've gotten through to the adulthood age. And but then they realize, what, college is too hard, and I need help. And that's when they try to get help. And sometimes parents also are to blame. They don't want to take the kid to the doctor and get them the help at a younger age, especially in our community. And so when I talk about this, not a lot of parents like want to admit that their kid has ADHD or symptoms of ADHD, even though I've seen it like from a young age in some kids, and I can tell like that kid may definitely need help, and he could do really well if he gets the help. But the parents just I know parents in my own church who have ended up abusing the kid, and CPS was called and things like that, but they don't realize they're trying to raise a unmedicated kid who has like severe ADHD and things like that. So anyway, nowadays it's very different. A lot of people have come to get help, and it is becoming less of a stigma, and as the kids are educated earlier and earlier. To kind of skip over into the diagnostic things, we also use different scales and report from teachers through the scales. So parents also complete the rating scales, and school teachers also complete the rating scales. And there are various types: the Vanderbilt, the SNAP 4, or the Connors, and different things that we can use to kind of specifically diagnose ADHD and ODD. And then broadband type child behavior checklists, which are like 80 some questions that the parents have to kind of sit down and answer to basically diagnose other comorbid issues as well. And then if you look at this diagram to make it easier, so at the preschool age, you may see some behavioral disturbance. As they get into school age, the behavioral disturbance is not just the issue, it's also academic difficulties and the peer relationship and self-esteem issues. Obviously, the child kind of may grow up feeling they're not smart enough. And intelligence is not an issue here, but they're going through those stages of development thinking they're not that smart. They're actually untreated ADHD kids, who compare themselves like any other child to the peers, and they just think like they're goofballs, they're people laugh at them, and they have to be class clowns and all that. That's the only way they feel appreciated and all that, but not by showing smarts and different things sometimes. Now, if somebody is able to be a class clown and be funny and all that, that also speaks to intelligence. But kids themselves, they don't see that. They'll actually report like, saying, things like I'm stupid and things like that, because they are definitely underperforming in the academics. So in adolescent years, the same thing, it's getting worse. The academic difficulties are like much more than, as you can see, the way it's set up, right? Self-esteem issues, legal issues may be there because now they're maybe, starting to dabble in, self-medicating themselves with either smoking something or the other. It could be marijuana or it could be just cigarettes, and then sometimes alcohol as well is a drug of abuse in that age group. And injuries related to like doing impulsive things, they may be risk takers in that sense, to um, you know, feel like part of a group. So sometimes they may be even joining, kids of similar issues, and calling themselves like a gang because they don't fit in with the regular folks. They're not normal, so they will behave abnormal. So they will become truant and different things like that. Then you have and get into drug use and all that. So then you have the college age. If they've kind of passed through all these years without too much difficulties, they're realizing their academic difficulties later on. But again, we see academic failure, occupational difficulty, self-esteem issues, substance use issues, and incidents, accidents happening. If they're driving a car and things like that, they may not pay attention to certain things and get into accidents, or they get distracted too easily with something else in the road and not paying attention to that they're actually driving also. So issues like that. Adulthood, similar things, right? So sometimes somebody else is pointing out that they need help, because they can't tolerate certain things, and they're coming to get help at different stages in their life. Okay, the pharmacological treatments, stimulants. I mentioned methylphenidate and the amphetamine class. Those are the two stimulant classes. And dexedrine was also one of the initial ones they, came out with, but that's probably the parent stimulant in one sense. But they're all FDA approved stimulants. Then the FDA approved non-stimulants, atomoxetine, viloxazine, and there's also Wellbutrin as well, or bupropion is mentioned here, even though it's in the antidepressant class. It's also kind of a FDA, approved medication that's used as a good medication when it comes to helping ADHD. So then there are, depressant medications that were used for ADHD in the past, but because of the dangerousness of it, they don't use the tricyclics. And then there are other stimulant-like medications that are not FDA approved, but also increases focus, like modafinil, memantine, and combinations of these. Then there's a different class in the alpha agonist family, guanfacine and clonidine, that can be given with stimulant medications. Either or can be added with the stimulant, and they're basically useful in the pediatric population, and it takes away a lot of impulsivity and can calm the kids down if they have behavioral issues and things like that. So I'll kind of wrap up ADHD with that, and if anybody has any questions, we can address that now. Okay, so again, this may be some, problematic kids. So there are a lot of, kids in our community who do have this issue, but they try to, they themselves don't realize it until later. But nowadays, with more education and, more, I guess, information delivered through teachers and, the school system, they are, kind of wondering. And obviously, there's also social media, right? That's promoting getting help for these kind of things, and they somehow find out that they have these issues, and even when internet was the only thing before social media. People used to find out, I think I have these things, I saw it on the internet, and they start to question it, and they have come to get help